Welcome to the University of Toronto Joint Centre for Bioethics Seminar Series. I'm Elizabeth Peter and I'll be the moderator for today's session. Our speakers are Jeremy Butler and Dave Langlois, and their seminar is entitled Moral and Conceptual Decision Points in the Design of Triage Protocols. Before I introduce today's speaker, I'd like to let you know that the seminar, as usual, is being recorded. This lecture, along with other archived lectures, can be accessed through the JCB's website. The format of our seminar is a presentation by our speakers, followed by a facilitated discussion period. We would like to take a moment to acknowledge this land on which the University of Toronto operates. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and most recently, the Mississaugas of the Credit River. Today, this meeting place is still home to many Indigenous people from across Turtle Island, and we are grateful to have the opportunity to work on this land. We also stand in solidarity with the ongoing protests against racism and systemic discrimination. Now it's my pleasure to introduce today's speakers. First, we have Jeremy Butler. He received his PhD in philosophy from Queen's University. He is currently a senior ethics fellow with the Centre for Clinical Ethics at Unity Health Toronto. The other speaker is Dave Langlois. He's also a clinical ethicist at Unity Health Toronto with the Centre for Clinical Ethics. So please begin.
Thanks so much, Elizabeth. Thank you for the introduction. And thanks everybody for joining us today. We appreciate the opportunity to talk about this project we're working on. Sorry, there we go, unable to share. So we're hoping today to talk about triage in healthcare, and in particular about the processes through which triage protocol documents are generated and the kind of structure and design of those documents. A little bit of background about sort of how we came to this project and what we're going to try to accomplish today. As everybody I'm sure is aware, the pandemic has prompted a lot of work in a variety of jurisdictions aimed at developing or revising old triage protocols, often for critical care resources in particular, with a focus on ICU beds and ventilators. We kind of first got interested in this or were sort of prompted to focus on it as a result of the pandemic. And that's kind of the background context. And I guess we're kind of been, part of what we're been prompted by is that the subject matter here is even rockier than usual terrain for bioethics. The stakes are really high, right? The shape of these protocols determines, in a quite literal sense, when they're activated, who lives and who dies, can affect how many people live and die and which particular people live and die. And the underlying philosophical issues, the conceptual and moral issues, are particularly complicated. Despite this complexity, there's actually been surprisingly little systematic work done to uncover the shape or the character of the underlying conceptual and moral issues of triage practices.
Do you want me to go now, Jeremy?
I guess so.
Okay. Yeah, I'll go. Okay. I guess to build on what Jeremy was saying. So Jeremy and I we both are philosophy people by background, but now we work in a clinical environment pretty much exclusively. I don't think either of us would ever talk this way, the way we're going to talk today, with patients or families or healthcare providers, not because what we're going to say is bad or offensive or anything like that, just because it's kind of like philosophy talk, and we normally abstain from philosophy talk these days. I think at least I feel comfortable saying that. I don't know if you do, Jeremy, but I think I mostly abstain from philosophy talk. But this is an area where I think we both think philosophy talk is required. And so we are going to deviate from our normal daily practice when we're in the hospitals and kind of put on our old clothes a little bit. So as a result, I mean, a lot of what we're going to say today is will maybe seem uselessly abstract or abstruse. Maybe some of it is, but I think that's partly because of where we're at in this project also. This is early days for us in working on this, and what we're going to be discussing is at a very high level of generality. So apologies in advance. Oh, this is the wrong, I feel like this is the wrong version of the slide deck, Jeremy, because it does have the sentence that stops it. So if you're able to throw up the one that has fuller, more complete sentences, that's really funny.
Yeah, sure. 1 second, you keep going.
Yeah, I'm gonna keep going. Apologies if any of this seems abstruse or too abstract. Eventually what we're aiming for is to develop a schema that has real world concrete action guiding application. That's not where we're at yet. That's not where we are yet. Please, if you have any questions, we would actually benefit from you asking the questions when they come up. Rather than doing the thing where like we talk and then after 30 minutes or so we go to questions. It would be better for us, at least. I don't know if it'll be better for you, better for us if you ask questions as they arise. So please do just jump in at any time, which weirdly you're going to have to do through chat. You can't actually jump in. So apologies.
That's absolutely right. So I think we are back on the correct
nailed it
slideshow. So
all right,
good start. Okay, so we can just to start off talking a little bit about kind of the scope and focus of the project. So when we talk about triage here, the idea of triage is used in all kinds of different contexts, but we're focusing on the healthcare context. And what we have in mind when we talk about triage are, in general, any practice that's aimed at setting priorities among persons presenting for care to some component of a healthcare system. And it's the practice of setting priorities among those people according to pre-established systematic standards. Now, on that kind of understanding of triage, this actually happens in a lot of different contexts in the healthcare system. We're going to be focused on circumstances where what we're doing is triaging access to a particular scarce healthcare resource or a particular set of scarce healthcare resources that have to be distributed over a population of people who need that particular resource. So you can see how this connects with the COVID-19 context, right, where the kind of surge in persons in need of critical care resources, and in particular ventilation, generates an increased relative scarcity of those specific resources. And what critical care triage for the pandemic contemplates is triaging access to those specific resources. So we're not kind of clear at the moment on exactly how this relates to all the different circumstances in healthcare where we might be triaging. It won't always be for a particular resource, but this is the kind of context that we're interested in.
One thing, Jeremy, if you don't mind me jumping in, I guess in a way of framing where we're at roughly, we don't think that what we're going to say today applies to, say, the kind of triage that goes on in a daily basis in an emergency department, but it applies, we hope, much more broadly than triage in COVID-19 concerning ventilation or something like that.
Yeah, I think that's right. And this is the kind of last point here, just that although we've been kind of prompted by the circumstances of the pandemic, we can imagine there are many different kinds of circumstances in which this type of triage is going on. I mean, we can imagine triaging access to a particular scarce drug or a particular kind of even surgical intervention, for example.
Okay, so why do we care about this? Well, I think there's two main reasons that we care about it. The first is instrumental or technocratic, but we're saying we care about it to just highlight it's not the thing we care most about, because it would be easy to confuse what we're doing with primarily being a concern for instrumental or technocratic stuff. So in a nutshell, you're likely to have a bad protocol if you haven't in advance thought through all of the decision points, meaning all of the things that you actually have to put into your protocol. You will have an incomplete protocol that has applications or implications you weren't expecting if there's not an appropriate schematization of the entire landscape. So just from a technocratic perspective, it's helpful to get it out in front of it by, in advance of drafting a triage protocol, having like that complex decision tree where you know in advance all of the different substantive and procedural issues that you're going to have to address. So if you're like a bureaucrat who likes protocol designs, a schema would be helpful. But that's probably, I think, at least for me, I think, Jeremy, you'd say the same thing, not what really motivates you, which is the moral or political legitimacy of these kinds of state interventions. So I think, uncontroversially, the legitimacy of a significant public policy intervention like triage depends on the satisfaction of some set of procedural and substantive conditions. What exactly those conditions are, we're not going to try to exhaustively articulate here today, but at minimum, in order for a triage protocol to be morally and politically legitimate, it would have to be the result of a conscientious, well-informed, and expert deliberation based on adequate public consultation and engagement, and be justified by sound arguments where those arguments are themselves grounded in publicly accessible reasons. We can talk more about what any of those things mean if you want to, but we're very inspired by the idea of trying to set standards for the political legitimacy or creating a schema which would assist in building politically and morally legitimate triage protocols. So one thing we want to just emphasize is that satisfying those above legitimacy requirements demands, at minimum, being appropriately attentive to the full range of structural and moral issues inherent to triage. So one thing that could help you do that is to have in advance a schema for triage protocol authorship before you actually get to the writing. That's all I got to say on that slide.
Sorry, I'm trying to. There we go. I think your comments just captured this to a great extent, Dave. But I mean, one thing to note about the legitimacy concern here is that this isn't something that's special to triage. It's not like triage protocols are the only type of sort of public policy document and associated intervention that have to satisfy those legitimacy conditions. I mean, there may be some reasonably minor issues in public policy where if you don't do that particular aspect of policy well, right, if you don't engage the right experts, if you don't do the right public consultation, that may not fundamentally undermine the legitimacy of an entire government or entire system. But I think it's reasonably clear that during circumstances like the pandemic, the stakes are sufficiently high that a failure to satisfy the legitimacy conditions that apply to triage protocol development is going to have significant consequences for any reasonable assessment of the overall legitimacy of the system. And I think what you said earlier also captured, Dave, the point here that the kind of technocratic or instrumental motivation of sort of getting a well-designed triage protocol is linked to the legitimacy issue. Why? Because if you don't kind of do the instrumental stuff, have a good understanding of the underlying conceptual or moral decision points that need to be addressed, you're going to have a protocol that's not well-grounded in publicly accessible reasons. And that is one of the conditions of legitimacy. So the two motivations are linked, but we can kind of separate them analytically just to see where we're coming from.
I have a question, actually. The question is, would this public consultation to meet legitimacy requirements include groups of patients, recovered COVID-19 patients and other recovered ICU patients? And that question's from Sandra Woods.
That's a good question. I mean, so I guess two things jump to mind. I'll just go first, Jeremy. So I guess in the specific context of the COVID-19 pandemic, and this is where what we say is going to seem unhelpfully abstruse, like we're flying at 35,000 feet. I guess I don't think I would want to weigh in on procedurally exactly what would be required in order to ensure the legitimacy of a triage protocol concerning the current pandemic. It would surprise me if it was possible to produce a morally legitimate protocol without that kind of consultation. But we're actually not going to talk about that today. We're actually not going to talk a lot about because we're not going to talk specifically about COVID-19 very much. So I don't know, Jeremy, if you have anything to add. It's a really good question. I would be shocked if you could produce a legitimate triage protocol that didn't involve that kind of consultation in our current circumstances.
Yeah, I would, broadly speaking, agree. Like in general, I would say that the extent and nature of the public consultations that one has to do for any given policy intervention will depend on the actual specific features of the intervention. And like Dave, I would think it's completely reasonable to expect that adequate public consultation for a critical care triage system during the pandemic would include engaging with those sorts of stakeholders, like sort of a patient perspective. I would expect that, but we're not going to make arguments today about the specific groups or stakeholder groups that need to be engaged with.
That's a good question, though. Okay, so back to so
I've
our
got-
goal. So, oh, sorry, go
A
ahead.
couple more questions if you
Yeah,
have.
yeah,
Yeah,
absolutely, sure, yeah.
Okay. Janice Kopanak is asking, what is the role of public health in this?
I imagine by public health we mean not the public's health or the concept of public health, but like people working for public health. I guess Janice won't have an opportunity to respond. But yeah, I mean, public health officials, well, it would really depend on whether you mean people with expertise in public health or like people operating in an official capacity with like a public health agency. Certainly public health should be engaged.
Yeah, I mean, I think public health experts are going to be among the experts who ought to be involved in the deliberative process that generates a document like this. There's no question about that.
Okay. And also a comment from Sylvia LeMay. She says, I think wider consultation than patients is needed. All citizens face risk of COVID and potentially need to be triaged, so all have a stake.
Well, and I really like that comment for the following reason. I mean, what we're talking about in triage circumstances are circumstances where you have limited public goods that are being distributed over persons who otherwise would have an obvious claim to them. So we're going to be denying access to public goods to some people in our community. So how could you not have the actual members of the community part of the consultation process? I think that's absolutely right. And those won't just be current or former patients. Those will be people who could become in need, who are not currently in need. I think that's exactly right. So our
a couple more if you have time.
Sure, yeah.
Yeah. Okay. Janice does clarify that she did mean public health agency.
Mm-hmm.
But Sandra Woods also states, definitely broader than patients. I asked because I'm involved with several groups promoting the push for patients included policy development and research.
Yes, agree.
Yes, I think we both agree with both of those points.
So what we want to do, we're not doing all this today, but what we're trying to do is schematize the conceptual and ethical questions that have to be addressed whenever somebody is building, or some buddies are building a triage protocol, and then analyzing what constitutes a sufficient answer to each of those questions. And again, this is not specific to the COVID-19 pandemic, although that's what got us thinking in the first place. The idea is anytime that you're faced with having to distribute a limited public health resource over a bunch of people who are in need and where they will not all get access, we want to build a model that tells you all of the questions that you have to settle in your protocol, and then also offer some guidance on what would count as a decent enough answer to each of those questions. So technocratically, to go back to what we said earlier, this will help just ensure that your protocol does all the things that it has to do. But more importantly to us, from the standpoint of legitimacy, we actually think that this will help authors attend to the foundational, structural, and moral issues where if they don't receive sufficient attention, you couldn't build a morally legitimate and a politically legitimate protocol at all. So a schema is not going to tell you the answer to any question. It can't tell you what you have to do at any of these choice points, but it can remind you that this is a choice point, and it's somewhere where you need to not just make a choice, but also offer an argument for your choice.
So with that in mind, we tried to, for today, as Dave said, we're not going to have every concrete decision space kind of laid out, but we tried to identify what we take to be some of the main, most salient categories of questions that need to be asked by protocol designers and addressed or answered within protocols. There, as I say, these will, in some cases, particularly some of the earlier ones, are going to seem quite abstract, and that's partly because they sort of bear on really the foundational moral questions that kind of need to be, in a way, addressed before you even start designing your protocol, when you're getting clear on what your protocol is even trying to do. So we're going to try and go through these, and again, we do welcome questions throughout, because we may have missed obvious stuff, and you folks can help us with that. So this is the list of questions, by the way, and we're going to try to get through them.
So maybe, Jeremy, I'll do the couple of slides on principles, then you can do the next couple of, just
Sure.
so that we're like handling the issues as a set, sort of.
Yeah.
So in a way, this is, I don't know whether this or the next question is the most abstract question that that protocol authors need to grapple with, but an example to start, using the current pandemic. So it's often suggested, and this is a version of this argument, or I don't even know if it is an argument, a version of this thought occurs in lots of different protocols, draft protocols across different jurisdictions, and lots of public health ethics in general. They say that, the move, what we're doing in critical care triage is grounded in a shift from an autonomy-focused framework to a utilitarian framework, or sometimes people will say from a patient-focused paradigm to a population-focused paradigm. And so because of this purported shift, these, pandemic protocols, or the triage protocols, will have like a long list of moral principles that are supposed to be specific to the new context, and they're intended to reflect this shift, this moral shift in principle. So we think that this is, we're not saying necessarily that that's wrong, but we're just saying that this is a suspect argument, or a suspect line of thinking that would certainly require robust argumentation. We think it's unclear why it is that the pandemic circumstances, or any triage circumstances, triage requiring circumstances, would actually justify less concern, say, for autonomy or for individual persons, or more concern for standpoint neutral states of affairs, that, like aggregative stuff having to do with purely consequentialist person neutral considerations, or for populations as a whole. Why not say instead that under the conditions of increased scarcity that themselves justify or require triage, that it's just our customary concern for persons and populations that justifies different healthcare practices, meaning we would have the same set of baseline moral principles, that consideration with respect to those principles in novel circumstances gives us different dictates or different verdicts. Next slide, Jeremy, because I think we have this captured in the next
Dave,
slide. So
I think this fits in with what you're talking
sure.
about.
Yes.
Because there's a question from Nancy, who says triage is already practiced following physician medical ethics, benefits versus harms, living will, etc. Are these constructs of medical ethics being considered? And I think that's
good.
what you
Interesting.
were talking about.
No, it's a good question. So two things about that. The first is that, just to go back, because I don't know the full meaning of the question, but just to flag one thing, is there's certain types of triage that we're not talking about here today, which are sometimes we use triage to refer to the kind of thing that goes in an emergency department, like day in, day out, or even like it to a certain extent might go on in how a nurse or a personal support worker organizes the level, the order in which they're going to attend to the patients who they're working with that day on shift. We're talking about triage at the level, at the distributive level over patients, where there's a fixed scarce resource, where all of the people within the or some subset of the people within the population have a need, an imagined need for that resource, and we're deciding how to distribute it over the persons. So that being said, the answer to the question, I think, is just yes. I think that's part of what we're saying. There's lots of moral reasoning and grounded in moral principle that occurs in contexts of medical decision making normally. And I think we're cautioning against the thinking that when you arrive in a situation that justifies triage, that you throw out all of that decision making and all of those moral principles, and you get new moral principles that are like custom tailored to the context of triage, and now you reason in this new way. I think the question that we're asking, and what we think requires more discussion and consideration, is whether it might actually just be that it's the same moral framework, it's the same moral principles operating, but just that deliberation with respect to those same principles, but in different conditions, produces different moral verdicts. And so, yeah, I think we would both say that the standard rules of medical ethics apply, but that the results of their application will be different in novel circumstances. So 2 questions about exactly, I think that's an answer to the question, I hope it is, but 2 questions about this thing that we should ask. So when and to what extent do the moral principles actually change based on the circumstances when we're operating? I mean, different principles because of different circumstances. Differently, when or how does deliberation with respect to the same moral principles generate different verdicts when operating in different circumstances? We think this is very important because if we're not clear about how moral principle is actually guiding and informing our triage frameworks, we run the risk, and we've definitely seen this, we're not going to, we're trying not to speak about any specific protocols here, but having read a lot of protocols nationally and internationally, there's a concern here that what we will wind up with is just like a set of principles, like ornamental principles at the beginning of our triage document saying, we're concerned about X and Y and Z, with very little attention paid to how those principles argumentatively actually inform the decisions and the verdicts of the protocol. So I guess the first thing that we're saying that a protocol has to be extremely clear and cognizant of is how it is that it's informed by moral principle. That's all I want to say about that, Jeremy.
Okay. Okay. So with that kind of, I think the moral principle discussion is useful sort of general background to the justification discussion. So when we contemplate a system of triage, right, we're contemplating a particular way of distributing scarce public goods to which, in a sense, we all have a kind of claim, but we don't have enough of them for all of us to get them. So when we distribute them one way rather than another, some people lose out. And it may be the case that we have equally good systems in the sense that we might have a system of triage, 2 systems of triage that will both save the same number of lives, but they may save different lives. And what this means is that we need to be able to justify, we need to give good reasons for choosing to initiate a system of triage. In our view, the justification of triage, it's an answer to a why question. It's like, why do this? Why distribute our scarce health care resources in this way? And the justification has to have a particular shape, right? It has to point to certain goods or values that are either realized, promoted, or delivered by the practice of triage that we want to initiate. So some common suggestions you'll see if you look at the literature on triage or on actual existing triage documents across jurisdictions. There are a lot of justifications sort of thrown around. One common one is to maximize utility. One suggestion is that triage can perform a kind of preserving function with respect to social cohesion or solidarity. So it can kind of promote trust in the system and trust in government. It can promote fellow feeling between citizens. And it may also be that it can play a role in preserving the functioning of a healthcare system. We don't...
Another question. Sorry to keep interrupting you.
Oh, no, that's okay. We asked for it.
Janice Kopanek has asked a question. I think that fits in with what you're talking about. She's saying, are priorities age-related, or perhaps should they be age-related? With scarce resources and a choice between prioritizing an elder with a middle-aged person with a family, and how is this situation dealt with, or perhaps how should it be dealt with?
Mm-hmm. Okay, so that's a really good question. Like it's an absolutely foundational question about the kind of substantive content of triage protocols. I think one is we don't have an answer to that specific question at the moment, but the hope in this context is that as we move through these decision points, we get to see kind of the sets of considerations that should be brought to bear on a question like that. So this issue of justification will bear on this to some extent, but we'll actually get to later on a discussion of kind of more specific types of criteria for making those specific triage decisions when you're faced with an actual choice between 2 or more patients, and you've only got 1 unit of the resource to dispense. I hope that kind of addresses that question. Sorry, Dave, did you?
Just to add to that, I mean, I think what we want to do is we want to help provide a framework so that that question doesn't just get an answer, but gets an argument, right? So we want to provide a framework that will allow, when we answer hard questions like that we don't just get a verdict. And unfortunately, that's the shape that many protocols take, is they as it were, tell you who will be saved. And in a very superficial sense, they tell you why, but they don't really tell you why. And I think what we're saying is that if we want an answer that's morally and politically legitimate to why one person is going to be prioritized over another, then there are certain things that we need to do first. And that's kind of what we're talking about here. That's a good question, though.
Yeah, it's a very important question. Thank you. So we canvassed a few. Again, we have these common suggestions, suggested justifications of triage, not because we sort of endorse one of them or all of them, but just to give you a sense of the types of values or goods that are sometimes thrown around. One thing that's worth noting in this context is that it's not the case that a triage system is or must be justified by one specific good, right? It can draw justificatory support from one or more of these sources or from other sources, right? That's totally possible. But it's also important to note that the different sources of justificatory support, if you think your triage system is based on more than one good, these can sometimes pull against each other, or they can constrain one another. And I'll talk about in a minute about how that might work. But the other thing I would mention is that the character of the justification should influence the design of the protocol, including its concrete objectives. So that kind of bears on the question we just had, right? So there's a kind of ground level question when you get to the hospital and you've got specific patients about how you're going to prioritize them. At this point, we just want to note that your answer to those specific questions should be traceable back in a way to the justification that you've offered for your system. It doesn't completely determine it, but it's going to play an important role in answering those questions. Oh, sorry, we'll get to objectives there. I want to mention just one thing. Sorry, I thought it was on another slide. One thing about drawing justificatory support from multiple sources. I think it's important to note that the way in which they might pull against or constrain one another. So if you had a triage system based exclusively on the value, say, of maximizing the medical utility of your available resources, it's going to look one way. If you base your triage system entirely on the value of promoting social cohesion or solidarity, it's likely to look a very different way. Under one set of justifications, the sort of democratic will, for lack of a better word, might sort of count much more significantly in the design of your protocol. In the other, if you're based purely on medical utility, to some extent, it's going to be much more rooted in specific clinical factors. I may have run ahead a little bit there, but I'll leave it there. Dave, do you want to do objectives, or do you want me to do objectives?
Well, just to expand on that, because who cares about the order in which we're discussing things? I mean, I think a very concrete way that you could see the justification, we're now going to start talking about objectives and whatnot. But if you have circumstances of triage where the primary justification has to do with social cohesion, trust in government, trust in the legitimacy of government, or trust in the healthcare system, say, you might wind up with a protocol that has a greater focus on transparency, meaning the actual transparency of the inner workings of the actual protocol decision making itself, than one where you have a brute focus on say medical utility, right? Where just kind of like robotic distribution with a focus on the maximization of medical utility, you might have less concern than at the level of objectives with concerns like transparency. So there was just a thing that I thought when you were talking, Jeremy, about just how concretely the justification question does inform more ground level stuff. I'll just say some objective stuff, then you can go. I don't think the order matters much. So it's important. We said that the justifications that one offers for a triage or system of triage is the answer to a why question. The objectives are an answer to a how question. So the justification, why are we doing triage? For such and such reason. Okay, how are we going to do that? So how is it? What are our local aims or the means by which we will realize the end that the justification gives us? So these can be very different things potentially. So we have 3 examples here of possible aims of a system of triage. One would be maximizing persons' survival of an acute medical episode. The other would be maximizing survival at some fixed period in time, 6 months, 12 months in the future. Very, very differently. You could have a protocol that was focused on maximizing total quality adjusted life years over, say, persons affected by the condition, or very differently over the total population. And then you could also vary the how you do the determination of qualities over a fixed period of time or an indeterminate period of time. You're based on what it is that you're actually trying to achieve, you're going to have very, very different local objectives in triage. And I think it might be on the next slide when we actually talk about prioritization, but the same way that the justification influences the objectives, of course, influence the priorities, the actual priority setting that occurs in triage. And that influences who actually does and does not receive care. So although this is all being carried out at an unfortunately high level of generality, I think what we're trying to say in part is that even starting from the very highest level question of justification, depending on how you answer those questions, you're going to get very different on the ground outcomes for particular people. And these are people that we owe explanations for why they are or are not receiving care.
Okay, and I also have a comment from Sylvie LeMay. And she says, if all humans matter equally, a lottery should be an important consideration in terms of triage.
So, I mean, so that's a really, it's a very perceptive point. One of the reasons I think that lotteries are often kind of show up in triage protocols at different stages of the protocol is precisely because they do, if conducted well, they have this kind of impartiality, right? They treat people formally equally in a really kind of obvious and concrete sense. And one way of doing triage in principle would be it would require all kinds of conceptual work to figure out exactly like who you randomize across and when you randomize them to decide treatment. But one way would be to try and do all of your triage just by random allocation. Now, one reason I think, not necessarily to endorse this reason, but I think one reason why many people might be reluctant to sort of have a system of triage based exclusively on randomization would be that doing that would involve sacrificing some other values which a lot of people take to be important. So if relying exclusively on randomization would result in many, many more deaths from the pandemic, say, then that is going to be viewed, at least by a lot of people, as a good reason for doing something in addition, taking into account more than just the outcome of lotteries. And in particular, taking into account at least some clinical factors that would enable us to make discriminations that lead to fewer people dying. Now, that's not necessarily to say that that's line of reasoning is right, but I think that's part of the explanation for why randomization or a lottery system doesn't sort of figure. Oh wow, I just changed this. Doesn't figure prominently as kind of like a primary triage criterion. I don't know if you agree with that, Dave.
No, I do. Although, I mean, and you said this in part, but I mean, I think we want to be able to provide an explanation for why and when lotteries are appropriate and inappropriate. And I think, like, normally most people have an idea about when they are and are not appropriate and inappropriate, and some protocols dismiss the possibility of brute random allocation of a limited resource. But I think what we want is not just the answer to that question, but a justified answer to that question. And so I think what we're trying to do is just trace why it is, how it is that one would have to go about providing the answer that random allocation is or is not the appropriate process for prioritization.
Okay, I'm going to try to. Okay, so I think at this point we've basically run this line of argument already. Overall, I think the important point here is that it is important to get clear on your justification. Your justification is going to influence your, or it ought to influence your choice of concrete, sort of locally defined objectives of your triage protocol, your triage practices. The locally defined objectives of those practices are going to you got to have an account of how those objectives promote or contribute to the good that the justification of triage depends on. And once that's settled, we start to move into a more fine-grained discussion about how actual prioritization processes need to work. Okay, so and I think this is some of the questions have kind of led to this. So once we've justified our system of triage and we've adumbrated a set of objectives for the system, we actually need to settle on criteria that people will use on the ground to prioritize particular persons over others. And this was raising the question about, if we've got an elderly person, then we've got a middle-aged person, we've got maybe a child, we've got to make these decisions. So we're going to have to depend on specific criteria, specific processes for sorting people into priority groups. And as the question about randomization or lottery sort of brought out, there are different categories of criteria we might use. And then within those categories, there are particular concrete ways of fleshing them out. So we can imagine a triage system based primarily, or in the first instance, on clinical criteria. So one sort of broad category would be expected mortality. So for example, if we had settled on the triage objective of maximizing survival, maximizing rates of survival of the acute episode of illness, then what we would want to do is we want to use clinical criteria. We want to set priorities based on clinical criteria that tell us whether the people presenting for care are likely to survive the acute episode if they are granted access to the resource. An alternative would be to use non-clinical criteria, right? So we have mentioned here what are sometimes suggested, very rarely, and I mean probably for good reason, very rarely suggested as the main or primary triage criteria, but it is in principle possible to take recourse to social or political types of criteria. So for example, one really, really objectionable and awful way of deciding of triaging patients would be based on their position in some social or political hierarchy, or based on wealth or something like that. But the point here is just that in principle is intelligible. We could do it that way. And of course, there are other categories of criteria that are more, I could call them procedural. They're not clinical, they're not social, but they're procedural in that they propose some process like randomization or a lottery process, or for example, some version of first come, first served. And of course, the criteria could be mixed, right? So we could have a triage system that took into account some clinical criteria, some social or political criteria, and the outcomes of some procedures such as randomization. And I mean, our thought here is like, well, one, just to highlight these possibilities and to note that it's not absolutely straightforward exactly how or in what combination we should develop our criteria. And also to highlight that kind of line from the nature of the justification for triage to the objectives of triage to the kinds of criteria that we're going to use, because what we're trying to accomplish with the triage are kind of internally defined objectives of the practice should influence which criteria we use. Right. If the aim of triage, if the locally defined objective of a triage practice is to maximize survival of the acute episode, then relying on social political considerations is not going to help you. And neither is relying on the outcome of a random allocation procedure. Dave, did you want to speak to processes of prioritization? I've lost you.
Yeah, I mean, maybe one, I don't know how far afield to take the conversation right now.
Oh, sorry.
So one concrete, one big difference that you see, we'll just go back to the example of the current draft triage protocols across various jurisdictions concerning critical care resources during the current pandemic. And you see there's two, I mean, there's actually more than two, but there's roughly two ways that we see this, the prioritization being cashed out on paper and in process. One would be, regardless of what your actual criteria are, right? Because we're not talking for the moment about the criteria, but the actual process of triaging folks. Once you have your criteria, there's one way of doing it where you cohort people into groups of people who will approximately similarly benefit from critical care resources. You could have, various numbers of cohorts of these people. And then within those groups, say, give equal formal access or probability of receiving critical care to each of the persons within those groups. Another way of going that's popular in more other jurisdictions would be just to, based on whatever your criteria are for prioritization, to set up an ordinal ranking system. So it could be a scoring system where people receive a score and then you convert that score into an ordinal ranking system, or some other means of just putting people on a list from 1 to N for their priority for access to critical care. Now, one of the interesting things I think that Jeremy and I have both observed in these discussions is that these different protocols arrive at different conclusions about the actual process of prioritization. And very few of them say much about why it is that they arrived at this outcome. So you could have protocol A that has a really specific or well-developed cohorting system for putting people into groups and then giving equal formal access to people in each of those groups. You could have another system that has an ordinal ranking system that uses some clinical criteria to produce a score where that score is converted in an ordinal ranking system. In both of them, you're going to have ties in the cohorting system. You're going to have lots and lots and lots of ties because everybody within each cohort is tied. In the ordinal ranking system, you're going to have ties when people have equal or relevantly similar scores, depending on exactly how that system works. And there's going to have to be then a process for breaking ties and so on. But one thing that we found across jurisdictions and protocols is that there's very little justificatory support given for why it is that this particular process of prioritization is chosen. Sometimes there will be like a paragraph here or paragraph there, something like that, but very little is often said. Now, we're not casting aspersions or blaming people for this at all, but I guess two thoughts on this. One is that this isn't something that we should be deciding on just because it seems right. Right? I mean, reasonable people have thought that a cohorting system was better, and other reasonable people have thought that an ordinal ranking system was better. And as Jeremy pointed to earlier, which system you use, even if you have very, very similar clinical criteria, which system you use can result in real world differences for which particular persons do or do not receive access to care. And we owe explanations to everybody in our community why it is that they and their loved ones in particular did or did not receive access to care. So since these are things about which reasonable minds can differ, we think it's very important that we produce on paper and for the public justifications for why it is that we're going the way that we go. And we actually think that sufficient attention to the earlier issues, meaning the justification for for triage in the first place, or your objectives in triage, or on the basis of those things, the priority criteria that you're going to use, that those things are the things that form the basis of your argument for the prioritization process. The more attention that you pay to those earlier things, the more you're going to have to say about why it is that you've actually chosen the process that you've chosen. And we think, and of course, like I said a moment ago, this isn't about blame or casting aspersions, especially the circumstances in which triage protocols often get written is necessarily rushed because the chips are down and we need decisions quickly. But this is exactly why having a schema for future protocol design could potentially be very, very helpful. And the second thing that I wanted to say on this is just a hammer on something that I think maybe Jeremy and I care about more than some people would. But we also think that it matters, regardless of how good your actual answer is, how tight and your argument is for the process of prioritization you've chosen. If for whatever reason, and there's lots of reasons that a protocol could fail to be legitimate, but if it's not legitimate, then we've failed the public, regardless of the actual content of the protocol. So yeah, and sorry, I'm just getting a call. Actually, I might have to take that, Jeremy.
Okay, that's okay. We're near the end. I'll try and say something about supplemental criteria. You can duck back on if you have time.
Yeah, well, we're really nearing the end. We have maybe like 2 more minutes.
Oh, okay. Do we have any questions? I'm sorry, I don't want to, I know we've tried to combine the questions with the presentation, but I don't want to preempt more questions at this point. What's the question situation?
The only thing I could ask is perhaps if there's somebody who hasn't asked a question, ask it now, because we only have a couple minutes left. Unless you just want to summarize, because that was a great talk, lots to think about.
Yeah, I mean, happy to sort of, in broad terms, sort of wrap things. I mean, one thing I would mention is just in this context of the discussion of specific processes for arranging triage criteria into an actual system that gives you priority groups of patients. As Dave mentioned, pretty much any reasonable version of this is going to allow for the possibility of ties between patients. It'd be very difficult to completely preempt the possibility of ties. And that means that basically, regardless of what your primary triage criteria are, and regardless of what system you have, you're going to need supplementary criteria that help you decide in the case of ties. In many cases, a lot of protocols end up relying on the types of procedure we talked about earlier, like random allocation or first come first serve or some combination of the two. But that's a conceptual point that I think we did want to mention. I mean, by way of sort of wrapping up, I think in my view, the main lessons here should be, we hope they are, one, that taking the time to kind of work through this stuff that is more conceptually complex and morally complex than it sometimes looks at first blush is important for the legitimacy of these documents. And even if I think today what we've gotten through is like kind of the main outline of the deliberative process you're going to have to go through. It starts at quite a fundamental level with an understanding of the role of moral principles in making healthcare, sort of systems level healthcare decisions, to the role of a justification of triage in the development of triage, the relationship between the objectives of a system and the justification of the system, and the relationship between the lower level priority systems that you develop, like your criteria and your priority framework, the relationship between those and the higher level stuff, objectives and justification. Yeah, Dave, did you have anything to add to that by way of it was a pretty whistle stop wrap up, but.
No, not really. I think that's basically.
Well, thank you. And I think that you really made it clear how important making all of those things transparent and well argued, rather than having them embedded or implicit in any kind of guidelines like this. So thank you very much. It's time to end the seminar, but I have a couple of announcements. Our next seminar will be next week on Wednesday, October 21st. Trudeau Lemons will be presenting on When Medical Assistance in Dying Becomes a Terminal Therapy for Suffering in Life, Critical Reflections on Canada's New MAID Bill. And if you'd like to sign up for that to receive the registration link, do so at jcb.info@utoronto.ca. And if you are a CSB student, please record that you were present at today's seminar. And Jeremy and Dave, thank you on behalf of everyone who attended. You've given us a whole lot to think about in a nicely argued and clear presentation. So thank you very much.
Thank you very much. Thank you, Elizabeth. Thanks everybody
Okay.
for joining. And thanks for your great questions and comments.
Yeah, thank you.